Hello and welcome everybody to the One Health Symposium of the Forschungskolleg One Health and Urban Transformation. I'm Dr. Timo Falkenberg. I'm the coordinator of the graduate school, and along with the doctoral students Anna Brückner and Ana Maria Perez Arredondo, we are going to walk you through the concept of One Health in our graduate school. Initially, I am going to tell you about who we are and what research topics we cover, and our One Health concept that we have developed. Anna Brückner is then going to tell you the conceptualization in the urban context that we have developed. And lastly, Ana Maria Perez Arredondo is going to introduce you to the policy framework that we have developed that we want to use to communicate with policymakers and practice partners. So, who are we? We are a graduate school that is funded by the Ministry of Culture and Science of the state government of North Rhine-Westphalia. And these Forschungskollegs, there's 6 of them in North Rhine-Westphalia, and the ministry is funding these to promote transdisciplinary research for the development of solutions to the complex problems of the 21st century. So what does it mean? We are trying to always foster cooperations between different academic disciplines as well as economic, political, and societal actors. So essentially, we are emphasizing the practical implementation of our research results. We're working together with practice partners, mostly from the political sphere, also from the societal sphere, CBOs and NGOs, to think about what topics are actually of practical relevance to those in the context of One Health. So who are we? We are 13 doctoral students, and we're working on 3 thematic clusters. The first one, how to ensure health-sensitive food systems, how to develop One Health governance systems, and how to promote health through the management of water systems. On the bottom left, you can see the One Health conceptualization, and what we see here that our clusters are kind of geared towards the different dimensions of One Health. So our One Health governance system, of course, is going about the entire structure. How can we create governance systems to promote intersectoral collaborations, to promote working between disciplines? Then the food system is the place where agriculture, environment, animals and humans meet, and that's why we want to focus on these food systems. And lastly then the water systems. Water is the connecting element. From agriculture, from animals, from humans, waste always flow into water systems, get recycled and used again and again. So a lot of health problems are associated, of course, with water pollution. We work in 4 research locations, in Sao Paulo, Brazil, in Accra, Ghana, Ahmedabad, India, and North Rhine-Westphalia, the Ruhr metropolis in Germany. Our consortium consists of our awarding body, which is the University Bonn, where all of our doctoral students will receive their degrees, either from the agricultural faculty, from the mathematical natural science faculty, or from the medical faculty that is situated at the University Hospital Bonn. Our coordinating bodies is CEF, the Center of Development Research, in cooperation with the University of Applied Science Bonn-Rhein-Sieg, specifically the International Center for Sustainable Development, ITSNE, and the UNU EHS, the Institute for Environment and Human Security. Lastly, we have our implementation partners that are situated in the individual research countries. So in Brazil, we have USP, the University of Sao Paulo. In Ghana, we are working together with the University of Ghana and the Institute of Statistical, Social and Economic Research, ISER. And in India, we're working with the Indian Institute of Public Health, Gandhinagar, IIPHG, which is part of the Public Health Foundation of India. And of course, as mentioned before, our funding body, the Ministry of Culture and Science. So what are we actually working on? So initially, we developed cross-cutting themes. Our cross-cutting themes are the connecting elements that connect the different topics together: water, hygiene and public health, healthcare, society, and food security. All of these cross-cutting themes are interacting with the three dimensions: human health, agricultural, animal health, and ecosystem health, which are the elements of the One Health system. So what do we work on specifically? We work on One Health governance in Accra and Ahmedabad, where it's about how do we operationalize, how do we implement One Health. We're working on the classical topic, antimicrobial and antibiotic resistance, which is the classical One Health topic, in Ahmedabad, in the rural metropolis, specifically in Dortmund, and in Sao Paulo. Then we're also looking at infectious diseases, waterborne and vector-borne diseases, which is a focus in the Accra region in our study. We also have urban agriculture and food systems that are explored in Sao Paulo and in the rural metropolis, specifically the city of Essen is the focus there. And lastly, we also have green and blue infrastructure, which was explored in Ahmedabad, in the rural metropolis, and also in Sao Paulo. So as you can see from these different research topics, it's a wide spectrum of topics that fall under One Health. And what is also quite clear is that we do not follow simply the classical One Health approach, which focus on zoonotic infectious diseases and antimicrobial resistance, but we actually look beyond these classical approaches to a more extended view of One Health. We want to go beyond the pathogenic focus, so the factors that are causing diseases, and also want to look into the salutogenetic factors, the factors that are actually promoting health. And this is what we see in One Health as a great opportunity, the idea of implementing health in all policies in order to create an environment where people, animals, and of course the ecosystem itself can be healthy and promote health, creating optimal health for all, rather than simply reducing the risk of infections. So how do we do this? So we looked at a set of frameworks that are already existing. One that is very commonly shown is the One Health umbrella from the One Health Sweden group, which essentially shows the different topics and different disciplines that fall under One Health. I personally like this umbrella quite a lot, because on the top we see the range of different disciplines that are involved: ecology, environmental health, public health, veterinary, human medicine, microbiology, health economics. It also shows in those green bars that we're looking at different levels. Now we're looking at the individual health, we're aggregating that to population health, and then we're looking also at the ecosystem health. So we see the different levels that are all embedded in each other. On the bottom, in those two spheres, we see the topics. And as I said before, it is following here a much more classical One Health view, where zoonotic infections are really at the heart of One Health. On the other hand side, we see comparative medicine, which is a discipline where we are comparing humans and animals to gain insights, for example, for the treatment of cancer or cardiovascular disease. Another important point that we see here, and that's on the right side on the bottom: environmental hazard exposure to humans and animals. And this is actually where I see the shortcoming in this conceptualization of One Health. Even though this umbrella encompasses quite a lot of topics, what we do see is that the environment here is actually viewed as a place of exposure, as a transmission medium. So rather than actually having a value on its own, it is reduced to being the place of exposure. So we have to go beyond this and see the environment as having a potential of health promotion in its own right. A very classical view of One Health is these three spheres: human health, animals, environmental health, that are simply overlapping. Here we have additionally a cloud of different disciplines and topics that are kind of part of One Health. But what is missing in a framework like this is actually understanding how are these different elements interconnected. What we are interested in is finding out what are those intersecting points. Another example of a One Health framework here goes in a little bit more detail. And we see here human waste, animal health, and how they contribute to the pollution of water, soils, and formats. But again, as I mentioned before, here the environment is seen only as an exposure medium. So the humans and the animals are polluting the environment, and the environment then spreads diseases to humans and animals. A very pathogenic approach. And we want to go beyond this and see the health promoting potential also. To sustainably create optimal health for all, we need to tackle the improvement of the environment and seek basically the co-benefits of environmental protection. So what we have created is our own framework. And here we actually placed urban transformations at the center, because our graduate school is One Health in the context of urban transformations. And we use different systems that are influencing either urban transformations in its own right or are affected by urban transformation processes. So on the top, we can see socioeconomic system, ecological system, political systems that are all being affected or are affecting the urban transformation processes. On the other hand side, we see those urban transformations affecting water systems, health systems, and food systems. So the wash infrastructure, the sewage management, the way we have agriculture, the way we practice agriculture, crop selection, food safety, and so on. In the health system, do we have access to healthcare? Do we have access to medication? Do we have access to insurance? And all of those, again, are affecting our One Health nexus, the interactions between human health, animals, and environmental health. But again, when we came to this conceptualization, even though for us it was quite clear that all of those are somewhat interconnected, it didn't quite help us to understand how those connections are actually flowing and how we can use this to integrate our different research topics. So what we did is actually create cluster frameworks. And even though I introduced earlier that we had those 3 clusters, we actually introduced a 4th one, antimicrobial resistance, because we saw that this one requires an own conceptualization. So in our top left, we see the framework for the antimicrobial resistance cluster. And what we can see is in the reddish color that we have the human side, the clinical setting or the community setting, where we have AMU, antimicrobial use. And of course, those flow, the waste of the human population flows into the water, into the wastewater system. On the left-hand side, we have in the brown color the livestock production, where antibiotics are also used for prophylaxis, for treatment, and in some areas of the world still for growth promotion. And this, of course, is affecting food quality. There might be residues, there might be resistance genes that might be still in the food, in the milk, in the meat products, in the animal products in general. And also it is flowing into the wastewater. On the bottom, we have the soil, the water, the plants. Also in the plants, the use of antimicrobials is quite common. And there's, of course, an interaction that these antimicrobials are then entering the soil, entering the water, and are basically circulating within that system. Overall, what we can see in this framework is that there is interactions of the different user groups of antimicrobials that are flowing into the water system, that are transferred via the food system, and are essentially then affecting the entire system again, just as one of the examples. Similarly, we have made a framework on the right-hand side for the governance, highlighting the different elements of the One Health governance system. On the bottom right side, we see our food system interactions. We have nutrition, where we have soil health, where we have sustainable productions that are interacting with each other. And on the bottom left side, we also have our urban green and urban blue infrastructure, which has effect through ecosystem service provision on animal health, biodiversity, as well as also, of course, human health. But even though we had now these different cluster frameworks, we were still not quite satisfied. So we continued our exploration to find an integrated One Health framework that connects our extended understanding of One Health. What we wanted to find is what lies at the center of these three spheres. What is actually at that intersect? What actually is One Health? And what we have come up with is this little diagram here, which looks quite complex at first sight. The first thing that we have done is that we have divided the biophysical environment from the social political environment. We're talking about environmental health in One Health all the time. And very often it is reduced, of course, environment to the biophysical environment, but there's a relationship between the biophysical and the social political. We place the biophysical environment at the center because the biophysical environment is at the heart of health. If we can provide a healthy biophysical environment, clean water, clean air, clean soils, clean plants, then we can also protect our climate, we can protect our environment and create a place where human health and animal health can be optimal, where it can be promoted. That biophysical environment is governed by the socio-political environment, by the governance, by the culture, by the human behavior, which is affecting the way we are interacting with our environment. And those are places where we, from the One Health perspective, can have interventions. The last innovation in a way that we conceptualized in this framework is that we split health beyond physical health. Health is more than the absence of disease, and we know that. The WHO has already told us this in the 40s, and this definition of health is very commonly cited. But in One Health, still, we are mostly reducing health to the physical health. To some respect, we might include the mental health, but what about social health? What about spiritual health? By separating out the different types of health, the different dimensions of health, it becomes much more clear that it is necessary to pursue a salutogenetic approach to One Health. How do we create optimal health rather than just seeking ways to reduce infections, to reduce the burden of disease? If we want to sustainably create health improvements, we need to tackle our biophysical environment, we need to promote a healthy environment in order to ensure that we can have optimal physical, mental, social, and spiritual health, not just in humans, but also in animals. Now I want to pass the word on to Anna Brückner, who is going to explain to you how we now took this idea of this extended One Health view into the urban context. Because here we still noticed, even though we had created this more expanded One Health view, that a crucial component of our graduate school, the urban side, was missing.
Hello, my name is Anna and I'm going to guide you today through the evolution of a framework for urban One Health studies. So as Timo has presented already, there is quite a large number of One Health frameworks, but none of these seemed really suitable for our graduate school. So we decided to develop a new framework that would actually be applicable to our graduate school. And we started thinking what are actually the integration points of our studies, and we came to the conclusion that all of our studies are taking place in the urban context. So urbanity is the characteristic of and the integration point within our graduate school. And as you know, we conducted research in 4 metropolitan areas with, of course, different urbanization dynamics and also different sociocultural city types. So for example, we have the European city type or the Latin American city type. And of course, all these different areas have different urban challenges or different urban problems. And also the city's vulnerability and the resources to overcome these urban challenges differ between the different areas. But still, the common point is that all of these areas are cities according to the general accepted criteria, size, density, and heterogeneity of the population. So here you can see some impressions of our metropolitan areas. And as I said, we have all the different types of cities. So we have, for example, Sao Paulo as an example of a megacity, which about 22 million inhabitants if you consider the whole metropolitan area. And we have, for example, Accra in Ghana as a medium-sized city of about 2.5 million people. And if you look at the density, this is also quite diverse. So we have, as a forerunner, Ahmedabad with about 9,900 people per square kilometer, and the Ruhr metropolis was about 1,150 people per square kilometer. And as all these quotes show, the cities are characterized by a diverse population. So in terms of ethnic groups, but also of castes or religious categories. So another important thing to keep in mind about cities is that cities are not only complex and diverse, but they are also dynamic. That's also why we have that in our title, urban transformation or transformative. So cities are affected by global development trends such as the climate change or political and social changes, but they are also driving these global development trends, for example, by emissions. And cities are also affected by internal or local driving forces. So as an example, in Ruhr metropolis, it's very unique about this German area that it is still struggling to overcome the ongoing structural change. And another thing to keep in mind is that research and practice have developed guiding models to promote urban development. For example, based on the concept of sustainability, we have the resilient city or the smart city, but these concepts stay very much normative and they have a limited feasibility. So what does this mean now for One Health in the urban context? So first, the urban characteristics, which I just presented, might increase the pathogenic interactions between humans, animals, and the environment. This is because in cities we have an artificial environmental design, which in most of the cases is at the expense of ecological health. So ecological problems are often externalized to the city hinterlands. In also many cases we have an increasing density, and therefore we have the danger of the emergence or re-emergence of zoonotic diseases, what we also currently all perceive during this pandemic. And therefore, cities have also been identified as pandemic ecosystems. Another fact is that the urban stressors or health risks for humans, animals, and ecosystems accumulate. So examples would be the emissions, but also the light and noise pollution or the city's microclimate. Cities are marked by sharp socioeconomic disparities. So we call them the urban or urban health inequalities. And these inequalities might also turn into urban One Health inequalities. So if we think, for example, about the distribution of environmental health resources and risks and the related disease burdens. So as an example, the risk for the occurrence of zoonotic diseases is much likelier in poor communities with a little provision of safe wash or with little provision of public services. And then urban characteristics can also enable salutogenic interactions between humans, animals, and the environment. So examples here would be the blue and green landscape design, but also that compared to rural areas, cities often provide a safer wash or they have a less pollen count compared to rural areas. For sure, one has to say that humans are the main beneficiaries of this general urban health advantage, which we know and just manifests in terms of better economic resources compared to rural areas or the better provision of healthcare facilities. But as I said before, we need to consider the inner city disparities. So in the end, we came up with another new framework for urban One Health studies. And as you can see in the center, this urban ecosystems, so we consider cities as urban ecosystems. They consist of the physical or natural environment, the sociocultural and economic environment, humans and animals. And the interactions between those different clusters can be categorized, for example, into food supply and nutrition, water security and sanitation, zoonotic and vector-borne diseases, or urban green and blue spaces. And for sure, this urban ecosystem does not stand alone, but it's affected and also affects the global and local driving forces and development trends. So these you can see at the outer circle. And the overall goal would for sure be One Health, which could be translated into urban ecosystem health, which would be the measure of biodiversity, natural features, ecosystem services, pollution and ecological hazards in terms of benefits or impacts to people and nature. As a conclusion, so the One Health nexus is likely to manifest differently within the urban versus the rural context. This is also one conclusion which we have drawn in our research brief, which you could read in the break. A framework for urban One Health studies that explicitly considers urban characteristics might help to guide research, but it seems still insufficient to guide urban policy making. And with that, I want to hand over to my colleague Anna, who's going to introduce you now our framework for policy making. Thanks for your attention.
Hi everyone, my name is Ana Maria Perez, and I will be presenting here the conceptual framework that will aid the operationalization of One Health. This is particularly important for policymakers. And this work was developed by Timo Falkenberg, Juliana Minetto, Krupali Patel, Denis Smige, Sandulya Sobant, and myself. So first of all, I would like to clarify that by operationalization of One Health, we mean to make this concept measurable and understandable, to be able to address the challenges of the complexity of health issues in the cities. If we look at the needs for operationalizing One Health, we have that the top priorities is a coordination of different institutions, that there has to be some integrated action at different levels of governance, that different sectors have to be oriented with some actions, and that the socioeconomic and cultural context have to be kept inside. So the processes for intersectoral collaborations needs a common understanding of the drivers of disease, the implications of the changes at broader scales, to identify the strategies to tackle those threats, and define clear outcomes. These components we identified by the work that we have carried in the graduate school, and also Timo and Anna earlier today presented other frameworks that have a common component on those four elements. So we were looking at frameworks, and we identified that for our purpose, the framework that I presented here, that looks at the driving forces, the pressures, the states, the impacts, and the responses, known as the DIPSER framework, was a very good tool, and it has already been used to look at the environmental health, human health interface. So this is how our framework looks like. And we have that on the top, the driving forces can be coming from global processes and local realities. And like just to summarize this at this point, the action for One Health comes where the umbrella is. So more specifically, on the top, the driving forces, they are rooted on changes at social, economic, political, and ecological spheres. Following, the threats that are derived from the changes and the driving forces. This can be grouped at different spatial scales, specific sectors, and population groups. The room for One Health action is identified here as the strategies, and it includes multiple actors and multiple sectors, for which the specific roles have to be identified. Also, the powers of those actors in politics and economics have to be defined. The position of those actors regarding the benefits and problems derives from solving health issues, and the perceptions of those consequences. At the bottom, we have the outcomes, which have to be as inclusive as possible to sustain intersectoral collaborations over time, and also to make sure that all the actors involved can in the long run achieve their institutional goals and priorities. To look an example of the application of our framework for operationalization, I chose a case of antibacterial resistance. And on the top we can see that the main driving force is an inappropriate and excessive antibiotic use in animals, plants, and humans. This is being impacted by aging population growth, overcrowding in urban areas, unhealthy lifestyles, intensification of agriculture, and unregulated access to antibiotics. The threats are present at individual levels, but also at bigger scales as healthcare facilities, farms, and the community. And particularly risk groups are elderly, children, farm animals, pets, and wildlife. So the strategy for addressing antibacterial resistance will be the reduction in the use of antibiotics. And this can be implemented by wash interventions, surveillance on antibiotic-resistant bacteria, and education. And this will have the aim to achieve the reduction of the burden of antibacterial resistance. So as closing remarks, I would like to say that the umbrella framework is very dynamic. It doesn't have to start as a top-bottom framework, but the outcomes can be used to define future transformation processes. And also the outcomes can determine the actors and sectors relevant. Furthermore, the threats, as those are usually the known instances for all, the threats can be identified, and from there the further elements of the umbrella can be filled in. So finally, I would like to say that intersectoral collaborations, particularly for One Health and the operationalization in this case, it's an iterative process that needs joint prioritization and consent. Thank you very much.